The overdiagnosis of osteopenia, essentially a state of pre-osteoporosis, is one of the most glaring examples of how medical definitions can be quietly redefined to expand the pool of potential patients, creating lucrative markets for pharmaceutical companies without necessarily improving public health. In this case, the change didn't emerge from new discoveries about disease, but from a subtle shift in diagnostic thresholds, one that transformed millions of healthy people, particularly postmenopausal women, into patients overnight. The primary beneficiaries were drug makers, most notably Merck, which reaped billions in sales from medications like Fosamax, alendronate, while the public absorbed the risks, costs, and long-term consequences of unnecessary medicalization. Bone density is measured using a technology called dual-energy X-ray absorptiometry, DEXA, which generates a T-score comparing a patient's bone density to that of a healthy young adult. The World Health Organization in the 1990s established a cutoff point of -2.5 for diagnosing osteoporosis. But crucially, they also defined osteopenia as any T-score between -1.0 and -2.5, not a disease, but a risk category. It was intended as a statistical reference, not a mandate for intervention. Yet this borderline condition quickly became medicalized, largely due to pharmaceutical influence. Merck, anticipating the launch of Fosamax, strategically funded educational efforts, sponsored bone density screening programs, and even supported the development of guidelines that recommended broader use of bone scans in aging women. The intent was clear: create a public perception that bone thinning, any bone thinning, was a disease in need of pharmaceutical correction. Soon, tens of millions of women were being told they had low bone mass and were at serious risk for fractures, even if their actual risk was minimal. The subtle redefinition turned the natural aging process into a disorder. It shifted the focus from treating fractures or actual osteoporosis to treating numbers on a scan. This risk inflation created a fertile ground for drug sales. Fosamax and other bisphosphonates were heavily promoted not just for treating osteoporosis but for preventing it, meaning prescriptions were increasingly written for women with osteopenia, many of whom had no history of fractures or other symptoms. These drugs weren't benign. While they do reduce the risk of fractures in high-risk populations, their benefits in lower-risk groups, those with mild bone loss, are far less clear. And long-term use has been associated with serious side effects, including osteonecrosis of the jaw, atypical femur fractures, and esophageal irritation. Still, the marketing marched on. Fracture risk calculators were designed to emphasize long-term probability, pushing more patients into the drug-eligible category. Direct-to-consumer advertising painted a terrifying picture of spontaneous hip fractures. Industry-sponsored physicians urged women to be proactive and stay ahead of the curve, often based on questionable interpretations of data. In practice, millions began taking powerful medications to treat a diagnosis that did not necessarily imply pathology. The financial incentive was massive. Merck's Fosamax alone generated annual sales of over $3 billion at its peak. Other companies soon followed with their own bisphosphonates, Actonol, Boniva, Reclast, further crowding the market and fueling the perception that low bone mass was a silent epidemic. As the population aged, more and more people were funneled into treatment, and bone density scans became a routine part of preventive health checks, despite limited evidence that such widespread screening meaningfully improved outcomes. And yet, while prescriptions soared, fracture rates in the general population did not decline proportionally. This suggested that the bulk of the prescriptions were going to people with relatively low absolute risk, patients unlikely to benefit from long-term drug use, but still vulnerable to side effects. In fact, by the late 2000s, concerns about bisphosphonate safety and the appropriateness of treating osteopenia began to surface more forcefully in the medical literature. But by then, the damage was done. An entire generation had been taught to fear their bones. This episode underscores a darker truth about modern medicine. Disease definitions are not always rooted in objective pathology. They can be stretched, molded, and monetized. Overdiagnosis doesn't just waste money. It shifts public perception of what it means to be healthy, erodes trust in medical advice, and exposes people to risk in the name of prevention. It reframes normal variation as abnormality and sells treatment as reassurance. The case of osteopenia shows how subtly this can happen. A scientific term is introduced. Industry-sponsored guidelines redefine it as a problem. Screening tools are deployed en masse, and suddenly millions of people find themselves labeled and medicated, without ever having been sick. It's not a conspiracy in the cartoonish sense, but a system that rewards risk inflation and penalizes restraint. In the end, the overdiagnosis of osteopenia wasn't a story of saving lives, it was a story of selling fear. And it worked.